Okay, is there anything I need to do to bring that up? Oh, okay, here we go. Right. Well, thank you for inviting me and sparing some time on the agenda for my little talk about the project that I'm involved in. Well, right around you here, because our patch is North Thames, which covers the most part of North London. So for those of you who don't know me, before I switched to the dark side and became a consultant with the IT Health Partnership and working with eHealth Links, I worked for the NHS for 20 years, and the biggest challenge I had during that time was dealing with interoperability issues, and it's one we didn't really crack. We hoped the National Programme for IT that we spent billions on would tackle it, and unfortunately it didn't, and it went very much down a sort of a mega suite proprietary road, which was an unfortunate missed opportunity. So I've been desperate to do something about that ever since, and 100,000 Genomes Project has provided us the opportunity to make some progress. So I'm going to talk to you a little bit about that. So this is the agenda for my short talk. I won't go over that. Okay, a little bit of background to 100,000 Genomes Project, if you haven't picked up on this in the news. It originally launched in 2012 as part of David Cameron's strategy, well, really part of the government's industrial strategy to kickstart the UK genomics industry as part of wider biosciences. Really to lever the opportunity of the population, particularly in England and Wales, 50 million people, single healthcare system. We could use that population base to really advance research and improvements in patient care. So the objective was to sequence 100,000 genomes across about 70,000 people. So the reason why those numbers don't quite add up is patients with cancer we sequence more than once, so once for their germline and perhaps more than once for the particular tumour in question. So to move the whole thing forward at pace, the government set up a company called Genomics England Limited to drive the whole project forward, and it invited groups of NHS trusts to work in collaboration to form what's called genomic medicine centres. So these are clusters of trusts, usually centred around a regional genetics service, covering most of the country, and there are now 13 of these up and running. North Thames, which is one half of London, is responsible for 15,000 of those genomes, although we're probably going to exceed that, and it's the largest in the country. Just to give you a little bit of an idea of the geographical coverage for the project. So those red dots are the centres, and usually there are clusters of hospital trusts around them working together as what we call local delivery partners. The idea is to try and reach as much of the NHS as possible, so we're trying to get more out into the provinces for equality of access reasons. Okay, so this is North Thames GMC. You're right in the middle of it right now. We've sort of got Bart's Health to the east, Moorfields just north of here, and Great Ormond Street, where I'm based, is the hub and where the regional genetics lab is based. But some quite big name trusts there that you probably recognise. Okay, so what were our challenges, and why did we pick up the particular approach that we did? So, great research project, alongside the genomic data. What they really wanted, as the researchers wanted and the clinicians diagnosing the patients, was quite a comprehensive electronic patient record. It was almost as if NHS England imagined that the National Programme for IT had been successful and every hospital had an EPR. They came up with this comprehensive data set. It was 1,300 data points approximately, covering all the usual things you'd probably expect in an EPR, so laboratory tests, radiology reports, lots of different observations depending on the diseases, etc. But unfortunately, they employed a team that didn't refer to the outside world, and they came up with a data model in a darkened room that didn't comply with any standards whatsoever. So that was a sad lost opportunity. And when we looked at that, we estimated probably 50 to 70% of those data points would probably be captured on existing local hospital systems in one shape or form. So we thought we could probably automate that. But we didn't want to really spend all the money that were being allocated for the informatics to build a solution that just served this one project. Like many of these great projects the NHS comes up with, but spend a lot of money, build a system, it runs for a few years, and then it just fades away, and the value's lost. So we thought this time, let's look at an open standards-based approach. We had issues to deal with around information governance, and obviously that's high on the agenda, and our thoughts around the architecture sort of bore those issues very much in mind. And of course, really what we wanted to do is leave a lasting legacy that could be used for both research, other research projects, and potentially for direct patient care. The unique thing about this project is it's not only just for researching in terms of finding out new things about genetic variants that could drive new therapies in the future, but it's about treating individual patients as well. So for a research project, it's quite unique that we've got patient identifiable data in there. Okay, so a little bit of background to this piece. We knew we wanted to go down an open standards road. We commissioned a piece of work to just look at what was going on in the market. I'd had previous attempts at this before, and I've got some colleagues I work with at the Royal Marsden, and we looked at the HL7 RIM there probably 7 or 8 years ago, and that wasn't implementable. We commissioned a research piece to see really had the standards moved on in those 6 or 7 years, and the answer was yes, they are. openEHR got a lot of traction. There's a lot of work going on with it. The market was becoming quite buoyant, so really that was the approach we should pick, and those are the sort of key benefits, most of which we've probably already talked about today, so I won't bore you with those. In order to convince our local delivery partners, who probably all had their own different EPR strategies, some of them were buying Epic or implementing CERN or best of breed, we explained to them how this would fit in with their strategy and wouldn't be a threat to them long term, because even if you're putting in Epic, it doesn't do everything. And you're always going to need somewhere where you can handle data from other systems. The other sort of key factors for us is the particular openEHR platforms we were looking at have been proven in large deployment, particularly Moscow, of course. And the work with other standards was key to us, and colleagues earlier talked about the needs for the semantic interoperability and the use of nomenclatures. Okay, so proprietary data models basically couldn't provide these benefits. And it was a bit of a no-brainer, really. Why would we build a proprietary system when we could implement openEHR? So that was the sort of lasting thought. So our approach to this, well, we had already collaborated with another GMC, Genomics Medicine Centre in West Midlands, centred around University Hospital of Birmingham, and they'd developed a software application for managing patient recruitment to the project, sample tracking, and acquisition of some clinical data. And we decided to collaborate with them on the development of their application. However, what we really needed to do is to lever that clinical data that was held in local hospital systems. So we worked with Birmingham on a strategy that would lever openEHR for that. And really what we needed was a platform that allows us to store data in an openEHR format. We needed some kind of ETL that was going to get the data out of those local systems and store that in the clinical data repository. And we needed a way of some kind of API for getting data in and out to surface that into the Genie product, and some way of querying all of that. So we looked at the openEHR standards, and we had a thought with Birmingham, is this something we should build or buy? And it just simply made no sense. No sense to build it ourselves when there were such good products on the market. So we set about a procurement process for that, and alongside that commissioned some work to develop some standard interfaces. So many trusts are already using standards for moving around the likes of laboratory data, for example HL7. Never quite the same in each organisation, but similar enough that we could produce some common tooling that could be reused. So this is more for the NHS audience, and apologies for that, but we did have to go through a formal procurement process that did mean getting a business case approved by the Oversight Board, so that's the chief executive of all those hospitals. And we bid for capital funding from the Department of Health to fund this, and we're pleased to say we were awarded that. And we had 3 very strong responses from vendors, and we also considered at that time an open source initiative, Ethosys, which you've probably heard of. Wasn't quite ready at the time. Times have changed on that, and if we had the time again, I think we'd look harder. So 3 great responses, and Marand won the tender for a number of factors. So what else did we have to do in terms of implementation considerations? So I talked about 70% of the data set. We probably, 50 to 70% of the data set we probably held in local systems. Well, about 70% of the data set already exists as data points within the openEHR standard. So we were only going to need to extend it by about 30%. Some of that was extending existing archetypes. Some of it was creating new archetypes. And probably the final third was really we need a conversation with Genomics England, because that's not the way it works in healthcare. And you probably need to think again about that whole modelling piece. And we commissioned probably the UK's experts to help us with that modelling, and that was Fresh Air. Ian and Hildy are in the room today, and thanks to them, without them we couldn't have done it. The other key piece was a metadata registry tool, so we needed some way of being able to track the provenance of all those data points. 7 different organisations, 7 different lab systems, 7 potentially different lab data models, all going into one database. We really need to know exactly where that data's come from and exactly what mapping we put in place. So that was another key component. And of course, building the ETL I've already told you about. So that's for the techies, that's a bit of a high level diagram, and thanks Tom, of really how it looks. So we've got 7 of these organisations which we call local delivery partners, and they've all got their local systems. We've provided them some ETL tooling, of which more than half of them have used. So that's some standard tooling from HR7, etc., to openEHR. A couple have decided to implement that directly using their own integration solutions, which is great. They're seeing the benefits of openEHR beyond this project already, and want to invest in that. So each organisation has its own openEHR repository. We're not building a single big database. We're asking them to sort out their data locally to normalise it to the openEHR standard. And then the Genie application here queries those 7 databases whenever we want to look at a particular patient for this research project, and we need to see some of that clinical data in order to send it to Genomics England. So this helps us manage a lot of the IG issues. It's really no different to any other clinical data repository that those organisations would have, except it's an open standard that we can federate and interoperate with. And then I mentioned earlier the metadata management tool is just for how we're keeping track of all of those mappings in all the ETLs, and that links into the integration engines locally, but also when Genie sends the data to GEL, remember GEL have their own proprietary format currently, so we have to map openEHR back to their standard at the moment. Or standard is probably too grand a word for it. Just a list of really some of the partners we work with. Key has been clinicians in there, but particularly some of the supplier community. We couldn't have done it without those guys. So our next steps. So beyond the 7 trusts in North Thames, West Midlands are committed to rolling it out to their organisations in their GMC, and that's up to 20, but probably 6 of them are actually going to implement openEHR, and that work's starting now. West London are also joining North Thames. We're thinking of the future and how we're going to mainstream genomics. Are we running out of time? I'll motor through this. one of the key things we want to do is, instead of just talking about this, we wanted to demonstrate what was possible with open standards. So that's a key message. I didn't get up on any stage until we had something that we could show, and we're just about at that point. And we think we can lever what we've built through our quite modest investment in terms of supporting development of federated clinical records across North Thames for research and patient care. So that's that. A whirlwind tour. Any questions?
So I think we do have time for one question for John. Paul, maybe if you could make your way up while we're doing.
We do a lot of mapping, I understand.
Yes.
How much of this is done automatically, and how much involves intellectual intervention by humans? And how do you make sure that in the end the data nevertheless all match? I mean, in the end you have to do some coding of the data, otherwise you can't integrate them.
Correct. At the moment, the mapping we've been doing, we've been focusing on particularly pathology and cancer data, because they're critical parts of the data set and they're quite high volume data items, and we understand that data quite well, but we've had to do that mapping manually. We are talking to some folk present in the room about how we might be able to automate some of that mapping in the future, particularly where we're using HL7, but each implementation of HL7 is different, of course. It describes the envelope but not really the content, and that's the challenge. We've also had to spend a lot of time around terminology mapping, and that's a big piece. It's no good storing pathology data if you're just using the local test codes from each organisation. So being passionate about standards, we're lining that up to the LOINC standard, and that mapping is going on right now. We're also looking at SNOMED wherever possible.
Okay, thank you.
You're welcome.
Thank you. Paul's just fighting with the technology, so